All right, so my name is Rich Bloch, and what I'm going to do first is we're going to do a quick run through of the folks that we have on the panel. We'll be talking about blockchain in healthcare and blockchain in healthcare. And we'll just do a quick introduction. I'm going to ask our panelists to just give me a one-liner on what you do, and then we'll come back around again and we'll go a little bit deeper about what you guys are all interested in. So Dave, you want to get started?
Hey everybody, David Hazel. My company Healthflow facilitates access to data for patients and gives them consent management on tracking on who's seeing their data and what they're doing with it.
My name is Anderson Nascimento. I'm a cryptographer with the University of Washington, and my expertise is in distributed cryptographic protocols, consensus protocols, that kind of thing.
Hi, my name is Suzanne Charlock, and I'm a product manager at Decent. We are administering healthcare plans to self-employed workers in Austin, Texas. We launched our first plans on April 1st of this year, and we're covering lives.
Hi, I'm Karen Stone. I'm an MD. I'm medical director of women's imaging at Evergreen Health.
I'm Brian Anderson. I'm the CTO of Lumedic. We're improving patient financial outcomes by connecting patients, payers, and providers.
And my name is Rich Bloch, and I'm the principal for a company here in Seattle called DigitalHealthcare.io. And I also happen to chair the Linux Foundation's Hyperledger Healthcare Special Interest Group, and I would love, if anyone is interested in blockchain in healthcare, feel free to come and join me. I've got some cards to hand out. We get together twice a month. It's an international group of 1,000 members. We'd love to have you here. So with that said, I'm going to go back through again, and I'm going to ask our speakers to talk a little bit more about specifically what they're doing in the healthcare field, because the great news here is not everybody here is doing blockchain. And the reason why we have speakers here to talk about things other than blockchain is because they present a facet of the technology. And when we talk about blockchain, it's really blockchain technologies. And it's really three things, and most of us are probably pretty aware of it at the moment. It's really DLT, distributed ledger technology, which most people think about as blockchain, so blocks chained together. It's also self-sovereign identity, or identity management, which you heard the folks just down the hall talk a little bit about. And it's also cryptocurrency, or in the healthcare space, we also think about it as crypto tokens, which is gamification and engagement from a patient perspective as well. So those three aspects. So not everybody is doing blockchain, but everybody has insight into using blockchain technologies in the healthcare space. And with that said, Dave, you want to sort of kick off a little bit more about what you're doing in Healthflow?
Yeah, so a little bit of background. My co-founder and I, Ken Allgood, started Healthflow because we were doing a lot of work with the Department of Defense and Department of Veterans Affairs and trying to just make data accessible to transitioning service members so that they could, one, see a longitudinal view of all the data that got collected about them across 10, 15, 20 different systems. Enrich that data with natural language processing to pull out codified concepts and help facilitate the bubbling up of the data that's relevant to whatever their chief complaint is when they went. So for example, they got referred over to see a cardiologist. The cardiologist doesn't need to see all the records, but they need to see a tiny subset that are relevant. And so we started looking at that. Ken is actually part of one of the Hyperledger working groups. So he's like, hey, we should really be using blockchain. We should be using Hyperledger specifically. And I'm like, okay, why? What are we going to use it for? He's like, well, we can do this. We could put the whole record on the chain. And we finally bubbled down to we're using the chain for consent management and tracking for the patients. So anytime anybody touches the patient record, requests access for data, views it, accesses it, we send all those to our essentially our audit trail in our distributed ledger, and then we're using it for that tracking, the consent management piece, and we're looking at ways to leverage it to facilitate GDPR deletes and CCPA deletes and things like that.
Perfect. Davis?
Sure. So Change Healthcare, we do a lot of different things, but we are exploring blockchain technology we have been for almost about 4 years in a number of different areas. So one of our primary businesses is we manage the claims and eligibility process during the revenue cycle management process between payers and providers. Around 60% of all the claims in the U.S. healthcare system go through our systems. So, and eligibility requests. One of the ways we've been exploring what the impact of blockchain technologies could be is through a claims transparency system, which effectively allows for that network to become more open and people to subscribe, right? Third parties to subscribe to what is happening to a claim, right? So if you're a trusted party, you can see if that claim is going through a chain, then what is the status of it? Where's the ownership of it right now? Right? Where is it in the process? And the second place we're experimenting with blockchain technologies and have launched actually, that launched about 2 years ago. The second one we launched is around optimizing the payment workflow, because one of the other things that we do is inside of payments processing. We manage the payments between payers and providers, and that becomes a very complicated process with a multi-party system, including lots of different banks. Right? Each entity in the system has multiple banks, and we were able to, using actually a platform built on top of digital assets, optimize that flow from a matter of days down to a matter of hours, and that one's actually been really successful. The first one I mentioned with claims transparency is actually built on top of Hyperledger Fabric. So those are the two main areas we're exploring right now.
Perfect. Anderson.
I have been working with several aspects of cryptography for the past 20 years. At the University of Tokyo, where I got my PhD from, I lived in Japan for many years, 8 years. Then afterwards, I was a research scientist with Nippon Telegraph Telecom. I was in Brazil with the University of Brasilia, and I have been for the past 5 years here with the University of Washington. And I have worked with identity management, credentials, proposing cryptographic protocols like digital signatures, encryption schemes. But my main area of expertise is distributed cryptographic protocols like consensus protocols that are at the heart of many of the blockchain applications. And my current research is actually in privacy. So usually when people think of encryption, you think of getting data, encrypting so that it becomes gibberish. And that's fine if you want to protect your data at rest, or if you want to protect your data in transit. You want it to become like garbage so that no one can do anything with it. However, what I'm interested in coming up with encryption mechanisms that protect the information, but at the same time allow you to do computation on the encrypted data. So the data is encrypted, but it's still useful for doing computations. And what I have been doing recently is actually developing techniques that allow one to apply machine learning algorithms on encrypted data. So one paper that we published recently, and that actually has been, I was attacked by Breitbart.
Hey, congratulations.
Because of that, so we actually came up with a mechanism that detects hate speech in text. And it does that without accessing the text directly. You access an encrypted version of the text with the special encryption mechanism that we designed, and you are able to flag, well, there is hate speech here or not. And hate speech is just one specific application. It could be something for detecting mental health issues, or my main area is how can we get the benefits of big data, machine learning, things like that, while keeping your private data private.
And also you're working with Dave through Healthcare, correct?
Yes, anything that has mutually distrustful parties want to do something together is at my heart.
Perfect. Excellent. Suzanne, you want to?
Sure. So Decent is a health insurance company, and we are offering plans in Austin, Texas for self-employed workers, and our plans are currently 20% cheaper than what a person could buy on the health exchange. We have the cheapest premium bronze plan in the Austin, Texas market, and a silver plan that's 20% cheaper than the average. We are a healthcare company first and a blockchain company second. We're exploring ways to make blockchain the most useful for our health insurance system. So we're trying to use blockchain to understand how to slim out waste in the health insurance market in the US. We all know there's a lot of waste there. We're hoping to do something with claims adjudication and also aligning incentives in the system. The US healthcare system has a lot of perverse incentives right now. For most payers to make money, they're capped at 20% of healthcare costs. So if healthcare costs rise overall, then most payers can make money. So we are looking for ways to realign incentives in the system to drive down prices for our members, specifically for 1099 workers who don't get subsidized plans through their employers.
Karen?
Yeah, so as an MD, I'm not currently using blockchain. I became interested in blockchain last fall, winter, just with a series of problems with medical record transfers. You've heard a little bit about this in the other talk. But ongoing problems, both for us, the physicians, as well as the patients, and and others. So looking for solutions, I kind of stumbled on blockchain. I really like the idea of immutability of data. I like the transparency in a consortium. I like the idea of a digital fingerprint. So that's what's drawn me to blockchain. Still investigating, but something I see as a potential workable would be blockchain smart contracts with use of interoperability software and handling medical records.
So Lumedic is focused on really improving the communication that occurs between payers and providers, and also bringing patients sort of back into that so that they're more at the center of healthcare administration. What we found as we dug into some of our own pain points that we've all experienced around our interactions with healthcare systems and insurance companies is that they become very, very siloed and very segmented in how they think about processes and how they think about the integration of these different parties and how they share data. So Lumedic came about as a way to improve that exchange of data, as well as improve how we can automate processes on the various parties and how they collaborate across the network.
Yeah, perfect. And one of the great things that I think we're trying to drive home here is that blockchain technologies are not a panacea. It's a very, very nascent technology suite, and really, it's not perfect for everything. It's very perfect for some very, very narrowly focused things, and that's part of what today's sort of conversation is going to really talk about, is where it's great and where it's not great as a technology suite. In part because it's such a new technology, we're trying to sort of fit this into sort of this round peg in a square hole. And so it's great to have sort of a reality check periodically with this new technology suite in healthcare. In part because healthcare, as many of you know, how many people are involved in healthcare directly? Good. Oh, great to hear. So what's really nice is that you know that healthcare is wedded so closely to academia that it's a very, very slow-moving, very cautious industry, and as a result, there's safety of life to consider, and as a result, things don't move fast. So any new technology, something shiny that might come along, it's going to be looked at with a lot of suspicion. And so we need to be very focused, and we need to be very sort of understanding of that domain space. And it's clear, I think, hopefully by now, that some of the shyness has come off of certainly cryptocurrency and some of the other domains as well. That there's really good fit here in some use cases, and then outside of other use cases, we just don't want to. We don't want to try to drive this home. Centralized architectures with a more traditional database is probably the way to go. So with that said, I also want to open this up to anyone. If you have any questions during the course of this panel discussion, please feel free to raise your hand. We want to be as interactive as possible. And again, we're time unrestrained in the sense that as long as you want to stick around, we're going to be here through about a quarter after the hour. So my next question, unless anyone has questions, next question to the panel, and this is open to anyone. In the healthcare space, how are blockchain technologies useful in a very specific way, where maybe outside of the healthcare space they may not be as useful? And I'll open this up to anyone.
Well, I can start. There's some kind of core issues that I think drive a lot of the costs in healthcare, and especially when you look at the administrative side of things. I think you're really looking at issues of trust, transparency, of friction around data access and data sharing, around friction around collaboration. And I think blockchain is somewhat unique in the sense that it offers a solution that facilitates partial trust and enables kind of the fundamentals of the technology, the ability to have trust of the network and of the process, and therefore of the data within it.
Of that question as a class of problems, I think in healthcare it kind of answers the question you were asking, Rich. The class of problems that I think distributed ledger technology and blockchain can help with really comes down
Through a query to say, well, give me my 5-year history of blood pressure. And I happen to be sort of scattered across 4 or 5 different healthcare systems. I don't want to have to query each one individually. We're using blockchain as a way to manage that, so that those queries are managed through the audit log. And then that way, what I'm getting is a one response that is that longitudinal answer that I don't need to worry about messing with, different interfaces, different systems. The notion of interoperability still is a pervasive issue that we still have to contend with, but it's certainly a simplifying aspect. Anderson, did you want to follow on with?
It's just a very quick point to what David said. So GDPR is this set of privacy regulations that they are used in Europe. And one of the qualities of blockchain is like, wow, you have this immutable, like a repository of data. And actually that goes against GDPR, because GDPR actually gives you the right to be forgotten. You can say that, erase my data. Do not want to have my data available anymore, or even I don't want to have my data stored by you anymore. So being aware of the privacy regulations of the place where you're going to have a business and how compliant they are with the technology choices you make, that's a crucial aspect, I think.
So is Healthflow?
Quick follow-up on that.
Yeah,
So
yeah.
there's two ways to tackle that. I'm not a cryptographer, I'm not a lawyer, just like, there's two ways to tackle that, Anderson. One is to have individual private channels, where forget about me, you just delete the channel, and correct me if I'm wrong. The other way that we're kind of headed is we actually don't have your data on our chain. We have a hash of your data on our chain that if you want to look up your stuff, we pull it from our data stores, run a hash on it, compare that to what's on the chain, right? So if you say forget about me, and there's a GUID that gets generated on our system that gets stored along with the hash of the chain. Forget about me, if we delete you from our system, and it's a unique GUID for every instance of a transaction, there's actually no way to, one, uncover the data that's living in the chain, or two, identify that for an individual patient, there's 5 records or 50 records or 100 records. So that's kind of, that second approach is how we're doing it right now. Again, not a lawyer, so.
It's a little ironic that GDP came along right about the time when DLT was touting the value of saying, yeah, we're never going to forget anything, and GDPR says, yeah, you have to. So there's got to be a way forward. So a good way to do it, just invalidate the hash or drop the hash, the link, so you break the link and then you're done.
I want to quickly follow up on the immunization use case. That was actually the core use case that started Healthflow. So my business partner has a kid with allergies. He was active duty. One of the things that happens in the military, you move every 1 to 3 years, which means new school systems, which means immunization records need to get updated and shared with those new school systems. And so we haven't fully implemented yet, but we're saying, okay, if we're tapped into the EHR systems that the DoD has, and we've got updated immunization through there, and we're already connected to a network in California. If you're transitioning from Virginia to California, just let us know that through however that happens, and we're automatically going to update your immunization records across the school that you're going to. My wife was a military brat. She's got still stacks of papers that she carries around and won't get rid of. She's like, do I need other EOB from when our first son was born? And that was 11 years ago. I was like, no, get rid of it. Right? If it was digital, if it was electronic, I'd say keep it. But honestly, there's too much stuff in our house, so just get everything out. So we thought about that use case. It'd be interesting to hear, if you want to dive in a little bit deeper about how that would actually work in practice. I don't know, Rich is moderating.
So Karen, you want to talk more about it, or I don't know how far down the path you've gone with this idea, but. Or is there IP around this?
No. It just I just see a need, actually, frankly, and it's an obvious need. I think it's not just school-age children. You're also looking at travelers, adults that need this sort of thing, need to have it present when going through customs various locations. So. It is a definite need, and digital format would make it so much easier. And I think, it would be a nice place for blockchain because it's a small amount of information.
Yeah. Davis, I'm going to ask you a question. So Change Healthcare is probably one of the first large healthcare organizations that implemented a blockchain solution. You want to talk a little bit about what the value add was, why you pursued a blockchain solution, particularly in the case of what Change was doing?
Yeah, talking about the claims transparency solution, one of the, and this gets back to the idea of the data reconciliation problem. right? And so what if our partners, our trading partners, insurance payers and providers, there's a lot of time spent in tracing down where a claim is, especially if during the claiming process something actually goes wrong with the claim. So when that happens, in fact, I don't know if anybody saw that excellent talk this morning about identity, but there was a great summary. Gentleman sitting back there, I would talk to him and talk about identity.
Well,
That was a great
let's
talk.
pick on Tony. So Tony, you want to stand up and wave?
Sure.
So Tony is a great resource. He's also, you're an ND, if I recall.
That's right.
And you represent Optum. And so Optum was, and we're going to go sideways for just a moment here, but Tony's a great resource for folks that are in the room that don't know. Optum really put together one of the first healthcare consortiums in blockchain. Do you want to talk a little bit about that, Tony? Just
Sure.
briefly.
So there's this consortium that we put together. It was about 1.5 years now, called the Synaptic Health Alliance. The founding members were UnitedHealthcare, Humana, MultiPlan. I'm going to get them on this one. I know there's like 4 or 5. Optum, obviously, and then there's a provider that I will get in a minute. And the goal is to experiment with a vertical use case across mostly payers around provider data is the first one. Just try to figure out ways to use blockchain to lower operational costs for use cases that, if any one of these entities solve themselves, would not be a real market advantage over the others. Right? That's a key, I think, one of the key pieces to this. And another key piece is if any one of the entities left, the whole thing wouldn't fall apart. So a good blockchain use case, think about Bitcoin the same way. If someone decides, hey, I'm not going to run my node anymore, well, the Bitcoin network doesn't fall apart. So the same kind of use cases. So provider data is the first one. The data is more or less a commodity already, but there's value for providers and payers to reduce the cost of maintaining those databases that are required for the health plan. We're doing other use cases that are coming into play, figuring out which ones we want to do next. So really still, we're in a production state. We're seeing value amongst the participants, and we're piloting others right now.
Perfect, yeah, thanks. And that was provider credentialing, wasn't it, initially?
It's provider demographics. There are like 5 or 6 data points that need to be tracked. When you go to your health plan, you say, I need to find a provider in my network. Well, you want that as a patient to be accurate. You don't go to the doctor and they're like, wrong doctor, or you go to the place and the wrong address, or they're not accepting new patients, but my health plan said they were. All these things need to keep up to date, and providers have to constantly they get pinged 4 times a year to go update it. Well, wouldn't it be great if you could do that just to one health plan, and then all the other health plans in the consortium would get the information.
So share the resource. So there's a great computer science or a single source of truth. So you have one place for the data, and I think it was touched on earlier, where you don't want to ever copy data because the moment you make a copy, the data could fall out of parity. And so single source of truth, and it's a shared resource, and there's trust that you don't have to really think about the other guy because you've got the DLT that's running.
Yep, and then you start building a marketplace around data. As soon as you have this narrow set of identities that you can track, you can start thinking about the economics of those networks, and those are the things we're thinking about next. Some interesting use cases will come out.
Perfect. Thank you, Tony.
Yeah, when you think about claims transparency, it's solving some of the same ideas, right? That there is data and there's copies of the data that are flowing through this large complex system, and it's important to realize that providers, and many people in the healthcare field here, but the providers sometimes get a very long life cycle between them and they get paid when they submit the claim. And where that claim is in the life cycle results in phone calls, it results in faxes, lots of phone calls to various people, and there's entire huge cost centers involved in just understanding this administrative burden, which actually we believe can be solved through the company claims transparency. So,
and I see Suzanne nodding her head. Do you want to
you
follow
have
up?
a question about there.
Oh, okay. Suzanne, hold that thought. We'll get to the question. Yeah, question.
All right, sure, thanks. My question is, so it seems like even though we're pretty excited about the integration, what's to keep providers from forming cartels against patients?
I'm sorry, could you repeat the question? I'm sorry.
Sure, all right, so what is to keep data providers from forming like economic cartels against patients, people that are more high risk?
Well,
I mean, all this integration, everyone's excited about that, but
Right.
it's not going to be on the patients. It's not going to expand the patient's agency.
Well, and that's actually where it comes in to be key, right? This is where we think that that's the next stage, is how do we get the patient to actually own and have that agency where they do control their data and they do understand, they can grant the rights and they decide. Because right now, honestly, What's to stop the potential cartels right now? Right? What are those
Without
insurance-
the patient in the loop?
Without the patient in the loop. All this happens without you in the loop. You get an explanation of benefits and you get a bill.
That's why open source claims adjudication using blockchain technologies is a really great use case, because right now Aetna already has the technology to do auto claims adjudication, and that's one of their unique resources that they claim as a company, and they aren't using it to lower healthcare costs for patients, and they aren't sharing that technology with the industry as a whole. And so if Decent were to use our claims adjudication blockchain technologies that we are thinking about creating, then they would be open source and something that we would want to share with the healthcare industry as a whole, and have those transactions validated by not Decent ourselves, but by people who are helping keep the system up and running, the miners, so to say.
I got 30 seconds to
Go for
rattle
it,
into
Dave.
that, and this is not blockchain specific. So two things that HealthFlow is doing specifically to address that issue is, one is building in consent management and tracking. So and wants to get access to my data. Can I approve? Yes, no. With a detailed explanation of why. The second thing is we build everything API first. So you would have the ability as a HealthFlow patient to pipe whatever data is going from your PCP over to the cardiologist into a personal health record of your choice, or your own personal blockchain, or a text file on your disk. I don't care, right? So we can't control all of the data, but enabling the better visibility and better access for the data that we are touching from the clinical data side, not the claims side.
So does that answer your question, or?
Yes, that was excellent.
Okay, hey Rich, can I add one thing to that?
Sure, Tony.
The reality of it, in my opinion, is its regulation. At the end of the day, the entire healthcare industry is incentivized to hold on to data and charge rent or extract dollars out of those who want to access it. And only through development of capabilities, bringing them forward to government. I know it's maybe not the most, in this kind of conference, talk about it, but the reality is that in the left and the right seem to have appetites to create a transparency for patients. I think the culmination of the technology and the regulation will be required to really break open these silos today.
Well, I think another great place where transparency is going to be really important is in health prices, so service prices. Basically, the US healthcare system is one of the only places where you don't know what the ice cream cone costs after you've already eaten it. Basically, you find out what your final price is going to be once you've already had the service performed, and there's absolutely nothing you can do about it. And so another solution that Decent is exploring is a price catalog, or a transparent pricing catalog, basically, so we could help our members understand what are the healthcare services offered at these different clinics around a certain area, and what are the different prices, and also what are the care outcomes, because we don't just want to incentivize, oh, this is the lowest price service, we also want to incentivize this specific clinician is someone who offers the best care outcomes and also has the best price, because overall better care outcomes is something that lowers costs overall. If you get a knee surgery and it's performed successful and you don't have to get 3 follow-up surgeries, that's going to lower the healthcare costs for the system overall, which hopefully would lower health prices for all members, because then the risk pool is lower and your what is the name? The guys who price everything, your actuarial model will be well balanced so you can lower your prices, but that's currently not happening. Right now, the health insurance industry is keeping all of these prices not transparent. They're not sharing with the consumer, and it's driving prices up across the board. So that's something that Decent as a whole is really hoping to lower, and we're hoping that we can use blockchain technology to really lower prices for members and eventually provide affordable health care for all, not just our initial target market.
I think back to his point, there's a role for regulation here, in the sense that pricing is something that does give people competitive advantage, and so they aren't incentivized to share pricing or to enable price transparency. That's where I think the government has to come in. Has already started to make moves here.
Yeah, there's legislation
Yeah,
that's
there's
starting to
legislation just
happen
recently
for-
passed around ensuring that providers advertise their sort of retail rates, but we all know that retail rates has nothing to do with what patients pay. It's a data point, but it's not the answer. And so I think, again, like regulation's going to have to come into play here to sort of force the issue.
So there's a question here.
Just a quick question, like, why does there has to be a special enrollment period in the insurance? Like, right now, I cannot get an insurance because I have to wait till that time. And is anybody working on this?
I can
It's
answer
like,
that.
if I buy a car, I can get an insurance just like that. But
So this loops back into the actuarial model. So basically, there's an enrollment period right now for people to sign up with health insurance to make sure that people don't sign up for health insurance right when you get sick. So let's say you don't have health insurance and then you get a really terrible diagnosis. Let's say that you get cancer and you realize, okay, now I need to have health insurance, and then you're going to sign up for a health plan. And it's a way for the health insurance companies to really smooth out their risk pool and get an accurate prediction of these are the premiums that we need to charge everybody per year to understand, can we get our costs covered for the next year. So that's why traditional insurance models are doing that. But our decent plans are actually offered all year round, not just during the open enrollment period. And so people can enroll anytime throughout the year, regardless of open enrollment. You just have to wait 1 month before your insurance coverage starts.
can I get in Washington State?
We're only offered in Austin, Texas right now.
Oh, so close.
Right, you're legislators.
How are you getting around that risk problem?
So we're getting around that risk problem by using the AHP regulations. So we're getting around that by understanding who our risk pool is based on the people that we're providing to. So we're only offering plans for 1099 workers within a certain cohort of NICS codes, which basically means, like, if you're a highly skilled freelance worker, let's say it's development or photography or anything like that, we can understand the risk pool based on your employment and your geography rather than just understanding during the year for one narrow area.
So young, healthy people.
Yes, sir.
Big fan of Decent, love what they're doing. And the thing that, from my seat, is somebody who hires a lot of people, as an angel who builds companies and teams, they solve an HR recruiting problem. Because the number one problem in Washington, when I'm trying to poach from Microsoft, Amazon, etc., the first question I get asked is, what's my healthcare plan? And there's no, because I'm hiring these people, this is what you have to do in early stage, you hire them as 1099s. I can't hire any 1099 employees and give them a match of what they have on Amazon, Microsoft, etc. So kudos for what you're doing in Texas. Can't wait to see it in Washington. Maybe we can pilot in Wyoming via Caitlin and bring it back to Washington, but that's not my question.
That's a good comment.
What I would love to see is, when I think about this whole space, is how we try to normalize the payer model. Like, I've built healthcare startups with two sort of payer buckets. One is public money, Medicaid and Medicare. The other is private. We all understand how that works, but they're not very equal. And when we think about building, sort of API stacks, take that world and try to normalize those two payer models, we're still struggling to try and figure out how do you normalize those two buckets. And I'm thinking, because we're in Seattle, we're in Amazon's backyard, they're entering this business. We all know that. They're going to be in this business, 18 months from now, 24 months from now, and they're going to disrupt the hell out of this business once they enter it. And so we're trying to think about how do we normalize, how do we create a common data model for, i.e. what we call the payers, once they enter that business. So love your thoughts.
Thank you.
There's a question.
So regarding this gentleman's question, do we want to try to tackle that, or any thoughts on that? And I'll just make an observation. One of the things that I'm noticing is, the larger players in the space, and Amazon being one of them, Walmart, Best Buy, some of these very, very large organizations, they're bringing their healthcare indoors, and the reason for it is they can cover their costs, self-insure, and actually make it worth their while to do so, which tells us something about the current model that exists. It doesn't seem to work. So there's a definite scalability issue. Yeah. Clive?
Okay, so my question is a little bit off the board. So following on the last question here about this deep data model, currently the healthcare is organized with companies like Epic Systems, where we have each hospital has its own data records. And as we go to like this common data records through APIs and so forth, My question is really for the cryptographer here on the panel. So this week we had the application, the deep naked application that will undress somebody. And it was in Vice and then it was pulled down immediately. So my question is, when we get these this data pool, how do we also secure the data, because we've got HIPAA and so forth?
So I usually listen to some people, they say, well, it's really great to put the data on the blockchain. Okay, so the data is there, and then we can work on the credentials for accessing that data. Other people say, well, you know what? We should use the blockchain just for establishing the access to the data. Like you can have the smart contracts and you can negotiate credentials, and then the data will be stored elsewhere. Okay, and then the blockchain is used for tracking what transactions are happening and which person is allowed to do what. And the second model, I think, would be my choice, because then you can still secure your data, you're responsible for it. You can make sure that you're not going to be sued because the data was misused. So it's this hybrid model where the blockchain is used for what needs shared governance, and that's basically defining who will access what and keeping a log of those things. And the data would be accessed elsewhere, and then you'd have systems that would integrate the data centers with where the data is stored with the blockchain in terms of giving access to the people who need to access the data.
A perfect real-world use case for that scenario is, and one of our advisors, and actually my neighbor, has had Healhcare, where you've got trying to make these decisions, somebody's near their end of life, they're expensive, $100,000 decisions, and you don't have the expertise, right? And the docs in the ICU, they're like, oh, we need to do this, sign off on this procedure, right? And you don't know. The ability to have a trusted third party that you can temporarily share the entire record or the entire relevant record with through a smart contract on the chain for 15 days. You're essentially taking, you're bringing on, the pinch hitter, adding them to the care team for this period of time. When the thing is done, solved one way or the other, revoke the access, right? So we think of HealthFlow, at HealthFlow, we think in terms of care teams, right? And one of the things that blockchain can do really, really well is through those smart contracts, enable that access, and that access really, okay, now David, you have permission to see records that live here, 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 and here. View the records, do whatever you're gonna do, contract expires, access goes away.
David, you make a good point, the notion of a pinch hitter. Well, I can imagine there's a great business model there that says, I want to hire in a professional pinch hitter in my healthcare space for them to be able to sort of review my way forward, and then they're gated for 10 days, 15 days, whatever it may be contractually, then they're gone.
How does our MD feel about that?
So one of the processes that we support is prior authorization, and this actually happens quite frequently. Through that process, you'll go for prior authorization of a procedure that the insurance company wants to review before they approve. And so before you actually go in and have your MRI, they want to know that it's medically necessary. And so they do sort of an initial take on that, and if they don't see the right things, they may deny it. Well, you have an appeal process that occurs, and there's a couple different layers to that, but one of the paths is for you to actually, I think as a health system, you can pay a third party to come in and do a medical review. And so it'd be exactly that type of use case.
I have one extra comment. One more reason for keeping the data off the chain is because of privacy regulation. So for example, if you have to be GDPR compliant, you have to keep the data in Europe. But if this data is distributed across a blockchain that covers different countries like here in North America and in Europe, then you are not GDPR compliant. So the problem with that is you have to build the interfaces that will talk with the legacy systems and acquire the credentials or authorizations from the blockchain. And that's no trivial thing to do. But I do not know if I answer your question.
Yeah, it did. And also, I think maybe I heard that you have specializations in machine learning and so forth. Maybe we can also use machine learning to somehow secure the systems as well as mine the systems.
But yeah, machine learning has been used a lot for intrusion detection systems or finding abnormal uses, and so yes, definitely there is a need for that. I call myself an amateur artificial intelligence person because I actually work with an expert in artificial intelligence, and our work in privacy preserved machine learning comes from this cooperation. Like we come from different fields and started working on this.
Well, so just as a point of order, it's about 12:20, so we are running kind of 5 minutes later. So I have one more question I want to ask the panel, but it's really up to you. Do you want to just sort of finish up with one more question? You want to do another round of Q&A? What would you like to do? Are you
I have a question.
Go ahead.
So actually, we were discussing around like data life cycle kind of thing, like emergency situation and things like that. Because there are a lot of people who are by themselves. They have no like somebody to say, okay, access my data this way or that way. They have emergency situation. How do you handle that? Like if data consent is needed from that person, like is there a way to like break it down? Like some clause in the system where the emergency happens, then this is the way the information can still flow to the doctors and service providers?
Yeah, go ahead.
No, I'm really briefly, and I'll have you answer too, but absolutely. I mean, what you can do there is, I mean, think about it like an if-then statement, right? You can say, well, I control my data, but what I can do is I can assign a delegate in case of a certain event. So making an event-driven model that says, hey, and you know, I show up in the emergency room, I'm incapacitated. Like right now, right? You can have bracelets or something that say, in this event, you don't normally do that. So you can actually have smart contracts enforce that in theory, right? And say, hey, in the case of this, grant temporary access for a period of time to this person. Now, identity management, this becomes a point of attack, right? So this is but you need some mechanism like that where it can be there, because you need to be able to delegate that authority, and that delegation authority will always be an attack point. You were going to.
I was just going to say that, I mean, the technology is not the blocker there in that situation. It's, you know, what are the state, local, federal laws? What are the providers willing to do or not do?
Think of it this way, like you're traveling, you're out of your family situation, you're in Europe, you're here, there's nobody who you delegated to even talk to. You're in an emergency. Your doctors need information around you, so how this happens?
Again, technology is not, okay, so perfect example, the allergy bracelets people wear, right?
Okay.
So it's got blood type on there, I'm allergic to these, and these medicines, right? One of the things that both paramedics supposed to do is check to see if they've been, I forget the name of them right now, but check to see if that bracelet exists, right? I mean, there's no reason that you couldn't have like your blockchain keys on your emergency bracelet, but you're not going to want to do that because someone can steal your bracelet, right? So it's not a technology problem, right?
So I would say one way in which these have been solved in other industries using blockchain is a model by which you require a registry for providers around the world that could register. And a combination of the key on your bracelet plus the key they have on blockchain would basically what's called in the healthcare system break the glass. You then have a cryptographic model that sets up the security associated with the right people accessing the record, and then you require them to write the fact that they've accessed that to the blockchain. So there's some creative things that people can do. In reality, though, it is not really a technology problem. It is a process that we have to figure out, and people have to agree to do it, and the technology would solve it. But we have to get to some agreement on how it is solved.
It has to exist by design. You have to design your system to have that in mind.
Yeah, and that's where I think it'll happen. It's just, again, in my mind, at least, technology gets closer to us, right? It was the phone and the computer out here, and you're typing, and now it's in your hand, and eventually it's going to get closer and closer to us. And how do we tie these identities together with these kinds of systems? Are interesting.
I think that's exactly the issue. It's a identity problem. I'm hearing a lot of conflation of DevOps principles and not having mapped the trust problems that are trying to be solved here, and other people talking about efficiencies. And after seeing, as a threat and technology professional in healthcare, and seeing 10 to 20 years of tech debt frozen, I have concerns about implementing blockchain functionality in an ecosystem. And I'd like to hear, I would like to hear this panel separate stock silo smashing and resolving the current ecosystem of healthcare with new opportunities and then the challenges of tying identity to those when that technology doesn't really currently exist in a viable way. Could you respond to that, please?
I think I can have, you see, the number one way that systems get hacked is by attacking credentials. So that's the weakest link in any information system.